Good morning, and I'd like to welcome you to the inaugural Medicine Global Health Grand Rounds. So the Department of Medicine and Department of Global Health have agreed to jointly sponsor two Medicine Global Health Grand Rounds per academic year. This is the inaugural presentation in that series. The speaker today is Dr. Carey Farquhar from the Department of Global Health and the Department of Medicine and the School of Public Health. And she will be introduced by Dr. King Holmes. King is the founding chair of the Department of Global Health and is now the director of, research and faculty development. I think I got that right in the Department of Global Health. So King.
Great, thank you. It's a real pleasure to be here to introduce Carey. She's our speaker today, and I think that the largest amount of global health international work, training, mentoring, fellowships of our UW internal medicine residents and trainees of anyone in global health really have her to thank for a lot of the work that they have done, that she's organized it. Since 2002, I counted about 150 dissertations, theses, mentorships, postdocs, master's degrees, PhD committees, and others that she had helped to coordinate. So she's really had a big impact on her trainees. And I think her own publications, now she's over 200. Many of them are with her trainees. She does a lot of clinical care at Harborview, and she has major research funding. Did I count 10 current research grants that you have? I couldn't believe it, but I thought I'd say it anyway, just to. So she's really been continuing to be original in the work she's doing. And I think last but not least, she's just been made Vice Dean for Education from the School of Public Health. So she's not only working with the School of Medicine, but with the School of Public Health. So with that as a quick background, it's a real pleasure to introduce Carey Farquhar.
All right, well, thank you, King, for that slightly exaggerated introduction, but that's what mentors, I guess, are supposed to do, right? Build you up, push you up. And King has been doing that for me for about as long as I've been working in Kenya, about 2 decades now. So I am incredibly pleased to be here, and also I'm very excited to see such a big crowd. I don't think I was expecting so many familiar and friendly faces, including many of my Kenyan trainees, some of whom may have to leave in the middle to go back to class, but I really appreciate all of you being here, and I want to also thank the organizing committee for having me here. Want me to turn it up? How's that? Is that a little better? Move it up a little bit? Okay, I think that might be good. I moved it. Great, so thanks also to the organizing committee for having me here to talk about my experiences over the last 20 years or so, building a sustainable clinical and research capacity in sub-Saharan Africa, but I will focus on work that I've done in Kenya with many others also in this room. So I have no disclosures other than to say that there are many beautiful photos of zebras that Mike Broad, the chief resident last year in Naivasha Hospital, provided me, as well as the case study is also courtesy of Mike. What I'll be talking about today are challenges building clinical and research capacity, and also making an attempt to share some best practices. But many times I'll be asking you questions and asking you to be reflecting on how we're doing, how you're doing, how we could be doing better. I'll talk about the the nature and importance of true partnerships when working in low middle income countries and when coming from a higher income country. And lastly, identify some opportunities for how we may do even better in our future collaborations, both in clinical and research settings globally, but also locally in underserved areas. There's a lot of overlap there. I'll start with a case study from Naivasha, talk about some ethical principles and best practices, go through the creation and evolution of our programs in Kenya, and with that provide some examples of effective collaborations and partnerships, and then talk at the end about the opportunities that I just alluded to. All right, so our case. The sound of hoofbeats is always zebras. So this is a 52-year-old man with HIV. He is adherent to first-line treatment for his HIV, tenofovir, emtricitabine, and efavirenz, and he's also on Bactrim prophylaxis. He presents with 6 months of fatigue, headaches, and weight loss. He endorses a mild dry cough. He denies fevers, diarrhea, or visual changes, or neck stiffness. And on exam, he's afebrile. He's mildly tachycardic with a heart rate of 112. Blood pressure is 106/74. He has an O2 saturation of 90% on room air, respiratory rate of 14. He has pale conjunctiva, he has anecteric sclerae, and a 3 out of 6 systolic murmur along the left sternal border. His white blood cell count was 3.2, with an absolute lymphocyte count of 900. His hematocrit is 17. So he's pretty profoundly anemic with an MCV of 64, platelet count of 132, and normal electrolytes, creatinine, liver function tests. The CD4 count is pending. That is a free test in Kenya due to PEPFAR funding. However, iron studies are not available and not done. They are available, they're just not done because the patient needs to pay for the laboratory testing that is not free, not HIV related, and therefore, the person is not able to afford that. The chest x-ray, which you can see there on your right, was read as normal. So what do you think is the most likely cause of this patient's anemia? Is it Mycobacterium tuberculosis? Is it a Bactrim drug effect? Is it direct HIV related marrow suppression? Septic ulcer disease associated with H. pylori, or a non-Hodgkin's lymphoma? You have to be thinking about horses and zebras. And this is, in fact, Mycobacterium tuberculosis, which, getting back to the zebra theme, is really not, it is a zebra in Kenya in that zebras are much more common. You are very unlikely to see a horse if you're driving down the road, whereas you will see zebras right and left. So the same is true, I would say, with HIV and TB co-infection, that it is quite common. And to have tuberculosis when one is living with HIV is not only common, but also contributes significantly to mortality, with 1 out of 2 deaths in this autopsy study from 2000 amongst persons living with HIV being attributed to tuberculosis. 80% of these cases were disseminated at the time of autopsy, and only half were actually diagnosed before death. In a study in Malawi, 40% of anemia amongst persons living with HIV was attributed to tuberculosis, a very common cause, large part due to the chronic inflammation that tuberculosis causes, as well as the direct bone marrow infiltration. I wanted to share this slide, and I think for those of us in global health, we're very comfortable looking at these, but I'm going to take a little more time describing what we're seeing here for those of you who might not be as familiar with the Institute for Health Metrics and Evaluation way of presenting various factors. This is causes of death in Kenya. And I want you to focus in on the red part of the diagram, which is causes of death that are infection. And what this is showing is that in Kenya, these are the various causes of death in this in 2016, and the size of the box is directly correlated with the amount of disease, the contribution of that cause of disease to morbidity, to mortality. So what we see is that HIV is contributing significantly, as is TB. And the other thing I want to point out, in addition to the size of the box, the color demonstrates that TB is actually increasing, has been increasing over the period from 1990 to 2016 as a cause of death. So why am I presenting this case? I'm presenting it because this is the typical case, one might see at Naivasha District Hospital. Actually, it's not district anymore, it's a county referral hospital, because it's been boosted from a level 4 to a level 5 hospital in Naivasha, Kenya. Level 6 being the highest, level 5 being just one level below that. So level 6 is the tertiary care hospital, the University of Washington Medical Center, Harborview Medical Center of Kenya, and Naivasha is just one level below that at this point. It has 220 beds, 70 maternity beds, and 8 specialists. So those range from surgery, pediatrics, across internal medicine. 7 medical officers who are generalists, general medical practitioners. 19 clinical officers, which is similar to our physician assistants, and 135 nurses. Mortality is quite high at 8%, and there are many patients who need ICU or intensive care unit level care, but there isn't an intensive care unit. There aren't ventilators for these patients. I think although we're doing internal medicine, not obstetrics gynecology, we have many of our colleagues from the OB-GYN department coming to the Naivasha hospital, and they are part of these 650 deliveries per month. Really a very busy hospital. And this is the hospital where we have established a clinical education program for residents, medical students, fellows, and others. From the internal medicine perspective, what we see is 340 admissions during the course of the month. There's a male ward and a female ward. This is the female ward, looking very bright and clean for any of you who've been there. This looks pretty much as good as it might ever look. And in that female ward, then about 225 patients would be admitted per month, 115 into the male ward. There is an even higher mortality in the internal medicine wards, with about 1 out of 4 individuals not surviving, and 10% of patients are living with HIV. So currently, for this ward, and I try to put yourselves in this situation, there is one internal medicine attending, called a consultant in Kenya, who rounds, not on an everyday basis, but a few times during the course of the week. There's a medical officer, again, a general medical practitioner. He's been trained across multiple specialties. 3 interns, called the medical officer interns, and the nurse to patient ratio is 1 to 25. So the question I want all of you to be thinking about as we go through these numbers is how do we send our residents to this hospital in an ethical manner? Because we have been doing this now for 8 years. This is our 8th year of the program. We've had 266 participants, 84 of whom have been internal medicine residents. 43 have come from the University of Nairobi, because one unique feature of this program is that we have University of Washington residents going to Naivasha, and we have University of Nairobi residents coming from Nairobi to this rural hospital. And in fact, we have 2 sitting in the second row, Abdallah and Hannah, because they're now visiting with us as well as part of an exchange. We have students going as well. 31 second and 4th year medical students have participated over these years. And last year alone, we had 22 University of Washington participants. And the observership is what Hannah and Abdallah are doing now, which is a 1-month experience at University of Washington to observe the clinical medicine that we practice here and the teaching, of course, that takes place. So the goal of the Clinical Education Partnership Initiative is to build clinical capacity in Naivasha. But there's clearly challenges in doing this. Very limited resources, incredibly stretched workforce, high disease burden, high mortality. And I think it goes without saying that it's incredibly emotionally and physically draining for all the providers, both those visiting, but especially those who are working in this setting on a day-to-day basis. Okay. So how does one build capacity when there is this constant tension between the need to care for the patients and then this desire to teach and learn, which everyone certainly has? What we have on the left are pictures of a new education resource center that we built. But it's very difficult to actually pull people away from the patient care responsibilities they have and allow them to participate in these activities when, on top of the existing workforce challenges that I explained when I showed the numbers, the actual numbers of patients and numbers of providers, there are strikes that have plagued not just Naivasha and this hospital, but all of Kenya. These are nationwide strikes, which is another talk altogether, the ethics of that. But in this context of these individuals not getting paid for months and months and months at a time, they have been forced to strike. And so you can see on this slide, then from October 2017 to March 2018, the doctors were on strike, nurses were on strike around that same time period. In fact, all healthcare providers, so hospitals, government hospitals essentially shut down in Kenya. And that was a period when we were working in Naivasha. At this exact moment, the clinical officer interns are on strike, and those are the physician assistant interns who do an incredible amount within the hospital. There are about 30 or so of them, and they're on strike at the moment. So again, what does one do when one has these types of practical challenges and trying to teach, build capacity? And I'll add to that it's not just these practical challenges, they're actually very profound ethical challenges associated with moving into a low resource setting and providing clinical care. In this position statement by the American College of Physicians Ethics, Professionalism, and Human Rights Committee, they talk about several ethical principles that they then base their positions on. What individuals who are interested in going to under-resourced settings, global primarily, but I would also say it's under-resourced in the US as well, and providing short-term clinical care. And so I'm going to share a few of those with you and encourage you to the paper itself, which is by Matthew DeCamp et al. So the first of these is the principle of beneficence. And in the position, the authors state that in all of these clinical activities, these short-term clinical activities that are occurring, there has to be an unequivocal focus on health and well-being of the individuals in the communities. One always has to be thinking about the host country, the community, what they actually want, and what is acceptable to them. These activities also cannot deplete local resources or interfere with what the local clinicians are actually doing, their work. And this of course can be challenging because we like to establish our programs and we think about what we're doing for our students and our residents. So I'm going to push you a little bit to think about it from a different perspective and keep that ethical principle in mind. The ethical principle of justice refers primarily to equity and fairness. And the recommendation here is that organizations and individuals must partner with local leaders to ensure that burdens that are placed on communities, because we will be a burden when we're going somewhere, that these are minimized. And when there are questions about resources and how resources should be used for these vulnerable populations, that we defer to the community and their values. Also somewhat challenging in these settings. And the third principle I'll talk about then is autonomy or respect, which is one of the most important and one that we instill into all the resident students who travel to Naivasha and work in this setting. The principle of practicing cultural humility and respecting all the social and the cultural differences, and trying as best as one can to mitigate these kind of power imbalances. One, in a way of doing that, is to invite conversations about needs and resources, rather than having all the decisions made by those individuals who have designed and are traveling, and open the door to these conversations. While this may sound obvious to all of you in the audience, it is much more complicated for those of us who are trying to establish effective programs that work, and yet also maintain these principles. So with Judy Wasserheit and Ruth Ndwati, who's a dear colleague and friend of mine at University of Nairobi, pediatrician, we were asked to write a commentary on this position paper, and had a few additional thoughts, and I'll just share one of them here with you, because it really stems from our experiences in Kenya. And I say our because it's collectively many individuals within Department of Global Health, Department of Medicine now. So the question that we wanted to also have individuals engage upon is whether or not it's even ethical to set up short-term programs like the one I was just describing when there isn't a long-term partnership in place. And why this comes up is that to create something that's truly sustainable, and also to have those dialogues that I just described, there has to be a relationship there that is deeper than just the initial encounter and what might happen when people arrive and are there for a very short time. So let me talk a little bit now about creation and evolution of programs in Kenya. The one I've been describing to you in Naivasha is the Clinical Education Partnership Initiative, which has a chief resident who's there full-time, and it allows residents to then go for short times, so residents from internal medicine and obstetrics, gynecology, and other departments, to go for short 4-week visits to provide clinical teaching and support for quality improvement and bedside teaching, but not replace the existing providers there. So I think that's pretty critical. So Naivasha is a more rural town, side of a beautiful lake, and they're pictured with the red dot. It's about an hour and a half outside of Nairobi. As I mentioned, it's now a level 5 hospital. It's brand new sign there. But this was not our first program in Kenya by any means, and I want to take you back to the 1980s and start with a program that's near and dear to my heart because I now direct it. But I wasn't the one who started it. It was started by Joan Price and King Holmes in 1989. And at that time, it was funded by the Fogarty International Center, and it allowed individuals from the countries you can see pictured there, multiple countries, allowed them to travel to University of Washington and study. short-term and long-term. What happened with this program over time is that it became increasingly Kenya focused, and that wasn't just us, it was the funders who said you must narrow and put existing funding in one place with the intent of building capacity within that place. You need to focus on institutional capacity building as opposed to what we're doing in the first, say, decade of the program, where you can see Kenya, Peru, Uganda, India, Thailand. There are multiple different countries involved. So the purple is Kenya, the dark purple. The gold is Peru, which is another very strong collaborative program that we have. And then you can see it, the gray is Uganda, which I think also has quite a number of trainees. But as you get to the out years, what you'll see is that increasingly all of our trainees are from Kenya. And it was on the foundation of this training program that we're able to build our clinical education partnership initiative, and also a very strong research collaboration with our Kenyan colleagues. The research collaboration part has been built around training Kenyans in master's in public health degrees, as well as doctoral degrees. Increasingly doctoral degrees, because as we listened to our Kenyan colleagues, they said, we need doctoral degrees to advance. So on the left, you can see that, again, the size of the box represents the number of individuals who have been trained with a master's in public health in the Department of Epidemiology. The Department of Global Health is younger, just a decade old, so we have fewer in global health, but increasingly our trainees are doing a master's in public health in global health. And a number have earned PhDs in epidemiology, in pathobiology, and in global health as well. And the histogram on the right then also shows how we're going from the brown gold color, master's in public health, now to more in the PhD range. 57 Kenyans have earned degrees. Several of these Kenyans have actually earned 2 degrees, both a master's and a PhD. We have more training appointments than we have individuals. But this allowed us to really establish the roots that we did in Kenya and then move on to clinical training. I saw my Kenyan students in the back smiling because this is, I told them I'd put this slide up for them. This is our current cohort of students, as well as our program coordinators. And increasingly, we have achieved more gender equity over time as well. You can see in 1989, 1999, during that 10-year period, majority were men, and now 2010 to 2019, the top 2 bars are about 50-50 in terms of gender. And we have short-term trainees as well as long-term trainees. We have about 10 here now. So research capacity, it's great, right? What could be bad about building research capacity? So thinking, again, along this, let's be cognizant that there are harms that can occur, and we want to do this in an ethical manner. I think one of the biggest harms that can happen is brain drain. And fortunately, our program has done a very good job, I would say, of not having our students train here and then stay here. But it's a constant, I won't say struggle, but we're constantly aware of it. And it's more complicated than simply saying you need to go back, because we also need to allow these individuals who now are highly trained, have a skill set that they want to use, we need to give them those opportunities back in Kenya. So we simultaneously need to be building capacity at those research institutions and working with systems so that we can allow our colleagues to actually own the research agendas. And this is challenging because owning the research agenda means you must be able to apply and be successful at obtaining that funding. And increasingly, working with others to to allow our trainees to be in that driver's seat to successfully obtain these grants, but it takes a considerable amount of work, and I would say it takes more than just individuals. It actually takes system changes. Grant funding that is designated specifically for researchers in low middle income countries goes a long way, because then the pool is very different than the pool for the normal sort of R01 or K series. In addition, the administrative hurdles that universities face when trying to submit grants, manage grants, and funding need to be addressed. Indirect costs for universities in low middle income countries are incredibly low. I think they're at 8%. So you counter that with what one might see here at 50 to 75%. You can appreciate that they don't even have the funds coming in to build the capacity they need. And so I put a shout out that if one has the opportunity, I think that's something we all need to kind of push for if we're going to make this a more equitable playing field. One program that did this was the Medical Education Partnership Initiative. And I'd just like to highlight how and why it did this. So the goal of this program, which was all over Africa, you can see, these were all competitive grants awarded to these different universities in Africa. Goal being to build human capacity for health in Africa by strengthening the medical education system. And doing this in an environment that values and nurtures research, because this was a collaborative venture with the National Institutes of Health, so more research oriented, as well as PEPFAR and HRSA, which is a service delivery arm of the government. The key difference between this grant and so many other capacity building grants is that the funding for MEPI, Medical Education Partnership Initiative, went directly to these non-US medical schools. And then the US institution was the partner. And this turned out to be incredibly successful in that it brought the schools together in the University of Nairobi and allowed them to do activities that, if the funding were in my name, I might not have done. One of these, for example, was bringing all the deans. This is a picture here of all the deans and chairs in the School of Health Sciences at University of Nairobi. So dentistry, nursing, pharmacy, public health, medicine, to University of Washington to meet with our leadership and explore the possibilities of expanding the educational efforts that were occurring at University of Nairobi and really centered at Kenyatta National Hospital, which is a large tertiary facility, and it's in an urban environment. So what they wanted to do is something similar to what we do here in Washington with the WWAMI program. So while we have a central hub at University of Washington in Seattle, and yet our students, residents travel to Washington, out to Wyoming, Alaska, Montana, Idaho, and other parts of Washington. They said, we can do the same thing, but we'd like to learn from you. So they brought everybody here to learn from us. They traveled to Spokane and Boise. And ultimately, this is how our idea for using Naivasha as one of as a place where it was feasible and I felt ethical to do more clinical training. It kind of spawned from this program. And the wonderful thing about MEPI is that, while the funding was just a 5-year award, it was refunded, not right away, there was a little gap, but as of this last year, about 1 year ago now, the University of Nairobi was able to apply for an additional 5 years to continue this effort. And now after the experience with the Medical Education Partnership Initiative, which I will say I really can, I think not just I, but many at University of Washington put a lot of effort into making that medical education partnership work, getting the activities off the ground, kind of shepherding things along. Whereas now with this one, which is entitled Health Professionals, because it's bigger than just medical education, it's ambitious, it has greater reach, it involves 4 Kenyan universities, not just University of Nairobi, and affiliated rural teaching hospitals. So it's carried forward this idea of taking research, clinical training, as well as research, because it has a strong and evidence-based program. What's unique though about having ownership in the low middle income country for a program like this is that they're not just able to better implement the program, but they're able to integrate this innovative curricula into their existing structures. So whereas we at University of Washington could never say you should have a program for undergrads that undergrads are medical students in Kenya that talks about evidence and research. They're able to do that. They're also setting up a master's program that's within their residency program that has a strong research focus. And they're able to do that. They're able to collaborate with the Ministry of Health and get these rural hospitals on board. And I put this photo on the left because that's the team, one of the teams that has been working on the grant. Dalton Wamalo on the far left is a pediatrician. He earned his MPH at University of Washington many years ago. And he's the co-PI of the grant with Ruth Ndwati, who's on the far right, also a University of Washington alum. And I will say Eliza Monroe Wise is third over from the left, and she was the first chief resident in the Clinical Education Partnership Initiative. So a lot of full circles here. And then we've got some amazing students over there doing a selfie, which I just couldn't resist putting in because it's really incredible, for me to see how enthusiastic and vibrant this program is. And I have the opportunity to do that because I'm on a giant WhatsApp group, and I keep getting these photos. They keep sending photos like this. Wonderful. So, why am I talking about MEPI and HEPI and CEPI? One reason is that I think those first 2 programs, like MEPI and HEPI, really have demonstrated to me the importance of moving from just collaborating on work to actually truly partnering on work. People may have different definitions, but when I think about collaboration, I think about working together on a specific activity. It could be a grant, someone who's collaborating and doing the lab work for you. Whereas with a partnership, there's vested interest in the outcomes of that work. There's also as I put here, co-mingling of resources and a shared leadership. And that doesn't happen all the time with collaborations. And I would encourage all of you to think about how can we move our collaborations further along that spectrum to being actually true partnerships. And it's not easy. And one thing to do is just look at the University of Washington academic partnerships that we currently have. This paper in the Lancet from 2008, I think, states well what the challenges are around academic partnerships. The quote, partnerships in the context of an uneven playing field and massive disparities in resources are clearly difficult despite the best intentions. So we can all have great intentions, but that's not enough. And there are still challenges that we need to overcome. Some of them I've laid out here is that as we collaborate with countries, institutions in lower resourced areas, here it was defined as north-south, that may actually come at the expense of collaborations that are national, local, or even south-south. And I think another very important consideration is that the institutions which we're collaborating may be benefiting, and we can say, yes, we're benefiting these institutions, but they're doing it at the expense of developing their own systems. So they might not be having to struggle to create their own grants management system or improve their budgeting or their ability to manage funds. And as a result, that dependency persists. I don't have answers to all of these. I'm just putting them out there. These are challenges. I guess one answer, though, is with that last bullet that really true ownership of the programs does require funding and control of that funding and control of the governance, which often comes with the funding. So simply making somebody a multiple PI, but then not actually putting them in charge of funding doesn't truly give them the same say in the governance or the experience that they might need. All right. So let's move back to something more clinical and think about how some of these lessons from research ethics might inform the clinical capacity building obligations. I do think we need to constantly be thinking about how we are helping the host facilities, the communities where we might be doing these shorter or longer term capacity building exercise. How are we assisting them in becoming more autonomous and providing them with sustainable solutions? Because in research, one thing we are all supposed to be doing, and I think increasingly, I know in global health, we're putting a lot more emphasis on this, is having a plan. So if your research works, what do you do next? No, you don't just say, great, I published, I'm done. You actually move it forward into guidelines, into policy. And that's not necessarily paid work because the grant funding is done, but that's an ethical obligation. I think for clinical work, we have the same obligations to be, think about what is our exit plan? We're not intending to be in this place forever. So think about what we might be able to leave. So I'm going back to CEPI, and with all that now that I've shared with you, you can think a little bit about what we're doing and what I think we're doing right. You can certainly ask me questions or pose differences of opinion at the end of this. But one thing I know that I said to Ken Steinberg when we initially started talking about having residents going for short-term rotations, clinical rotations at a hospital where we were already doing work through this MEPI, the Medical Education Partnership Initiative program, was that we needed to have someone there who was a constant. And so one thing I think we're really doing right with this program is that we have a chief resident there who's living there 12 months out of the year, and in that time period able to establish rapport, really understand the needs and the realities of it, and even check me if I say something that they then say, that's, we can't really do that here at this time. It's not, there's a strike or whatever it might be. The other thing I think we are doing right is having an exchange. Not all programs have exchanges, and often we've had to fight for them on the global health side. Joe Zunt and I have often had just put our foot down and said, no more medical students are going to Peru, Kenya, Uganda, unless some also are able to come to University of Washington. And then when the money thing comes up, it's like, find the money, we'll find the money. So we have been able to bring University of Nairobi residents, not just from Nairobi to Naivasha, but also to University of Washington. And that's been really special. And it's kind of win-win on all sides. We've also brought hospital leadership to Seattle, not for the last couple of years, because there's been changes in leadership, and the current medical superintendent was just pregnant and had a baby. It's kind of hard to travel, but we will again. This is all built on this long-standing partnership with the University of Nairobi, and now we've been with our Naivasha Ministry of Health partners for about 8 years. And I think the other thing we're doing right is that this is a collaboration across the University of Washington as well. Support from Department of Medicine, Department of Global Health, and obstetrics gynecology have always been big players in that. So on the upper panel there, that's Naivasha. That's Crescent Island. We have all kinds of wonderful animals wandering around. And you can walk with the giraffes and the wildebeest, the impala, and the hippos. University of Nairobi is on the bottom left, and obviously University of Washington. So now I'm going to move into the last part of my talk, which is providing some of the sustainable solutions that people, the residents, the chief residents have come up with in Naivasha. And I think these are really exciting, and they change. Some work, some don't work. Colette Abbott, shown on the bottom left, is the current chief resident in Naivasha, doing a fantastic job. And she's there training one of the R3s, Lauren, who's there. That is actually not a real patient. That's one of, as Colette put it, a model. So, but so we could demonstrate the use of a butterfly IQ ultrasound. So it just attaches to the phone. It's a small probe, and it's something that is feasible there. Yes, there are ultrasounds, but they don't seem to be moving them around and using them. Whereas Colette being able to do this at the bedside and also then in trainings is finding great interest in that. The other thing that is happening now is several low-tech simulations. So whether it's deliveries with complications, or even doing lumbar punctures, or other getting vascular access, using the ultrasound for vascular access. These are all very carefully kind of thought through before they're introduced to ensure that it's not just a one-off, but something that we'll be able to carry forward. There's an internal medicine core curriculum now in Naivasha. Interns in Naivasha, the medicine interns, rotate for 3 months through each of the 4 specialties. So they do 3 months of surgery, pediatrics, obstetrics, gynecology, and then internal medicine. So when they're in internal medicine, they have a core curriculum that is available to them both in sort of hard copies as Pocketcards, which was initially how it was developed, as well as now as apps. And each resident from University of Washington who goes to Naivasha is responsible for coming up with one of these. So it may be hard to read, but it's organophosphate poisoning is one. Naivasha is a leading flower producing place. And as a result, there are a lot of pesticides, and actually intentional overdoses occur, not infrequently, unfortunately. And the second, so DVT and PE, but this card would look very different than how it would look here in Seattle. It's created so that what's on that card is what's useful and available in that setting. This core curriculum, I should also say, is taught to all the interns and medical officers as they're in internal medicine, with not just morning report, but weekly CMEs. So we've got the Pocketcards and then also didactics. So we talked about ultrasound, low-tech simulations, pocket guides, apps. The other thing that's ongoing is radiology and EKG telehealth via WhatsApp. So WhatsApp, great program if you need to talk with people over the internet in other parts of the world. And what's happening is that Colette was telling me the residents, she will take pictures of the x-rays or the EKGs and then WhatsApp them to various pulmonologists, radiologists, cardiologists here in Seattle, and then get feedback on those. So it's telehealth, but particularly around radiology and cardiology. Critical results reporting via either WhatsApp or SMS is something else that's been instituted. So the laboratory may get a critical result, but may not communicate that because there aren't landlines or telephones there. So a system was established by Odessa Laxina, who's there on the right. She was a Fogarty Fellow and is the wife of Josh Laxina, who was one of the chiefs. And she has a laboratory background, so she established this system. And then lastly, different chiefs have come up with different themes that they've wanted to emphasize. So Josh emphasized leadership training and did a Wednesday evening dinner at his house. Let's talk about leadership in the clinical context. And Andrew McGinnis talked more about wellness training. And on the heels of the strikes, I think the wellness component was absolutely critical because there's been so much upheaval and so many challenges in terms of workload. All right, so I'm going to end by talking a little bit about how this global health talk may also be highly relevant to what we're doing here in the WAMI region by speaking about a 2-year fellowship for internal medicine residents that is directed by Jason Bestie and involves spending 1 year in a rural underserved area within the United States and then a 2nd year in a global health setting. So Pine Ridge Indian Health Service Hospital in South Dakota is one of the sites, and the Alaska Native Medical Center, as well as Bethel Hospital in Alaska is the other. So our fellows, and we have 8 at the moment. We've had 8, 4 have graduated. Spend 1 year there and then go for their 2nd year to a variety of places. All 4 of our graduates are now employed back at their rural hospital where they did their initial year, which I find absolutely fascinating. So we have total of 8 fellows gone through the program, and 3 are now back in Alaska, and 1 actually just started her position at Pine Ridge. So there's just so much overlap between what we're doing in global health and these more local underserved areas. There's Andrew McGinnis, Chief 2017-2018 with his that's with his group in Alaska. I think that's in northern Alaska. So I'll end by inviting you all to Kenya, Karibu, Kenya. This is the new William and Jane Bremner Education and Resource Center, which was built during Mike's tenure there. I think Mike learned an awful lot about construction and contracts, and now Colette's learning a lot about doors, which is wonderful. But it's really exciting, and this center is there for all these educational activities that we do on a weekly basis, but it's also there for when University of Washington anesthesia comes, which they're doing next week, to do a simulation and to invite the larger community in. Lake Naivasha is a beautiful place. So I am just presenting actually almost a thumbnail of the work that's being done in Kenya. And there are many, many people to thank in the Departments of Medicine and Global Health for support of the CEPI program in particular, the Fogarty International Center for our International AIDS Research Training Program support, and all the faculty, staff, students, fellows in our Kenya Research and Training Center in the Department of Global Health, the IRTP, all of our Kenyan colleagues, and then of course our Naivasha County referral hospital leadership, chief resident, residents, students, local providers, and everybody else, if I've forgotten you. So thank you very much. I'm going to end with just one quote that I love, and I changed the photo from Mount Kenya to Mount Longonot for this, because Mount Longonot, this mountain is just right outside of Naivasha, so you could climb it and walk around the top if you have a day and the legs. So all things are possible if you just take it little by little, step by step. And I think that's what we're doing with this. We're in it for the long haul. So thank you very much.
Thank you very much. What questions do you all have for Dr. Farquhar? Go. Come here. Come here first.
Thank you very much. That's really interesting. I've thought that health services rise on the back of economic development. What's the prospect for economic development in this area of Kenya? Will it support better health services?
That's a complex, kind of loaded question. Kenya actually is doing very well economically. It's been politically stable for many years, decades. Okay, Ken's shaking his head. Yeah, there have been a few issues, but more politically stable than in other parts of Africa. And it's doing well. I think there are big challenges around leadership and governance. And so I don't think economics is enough to actually get health systems funded and in place. Because even with a government that is well funded, what's happened in Kenya, at least, is they decentralized that funding. So they put the counties in charge of then funding healthcare. And there's not the experience, the knowledge, and even the will to pay the doctors, pay nurses. Instead, they're investing in ambulances and infrastructure because that's what kind of can make the front page and look showy. So I think it takes more than economics. I think actually resources need to be used wisely. But I would, of course, defer to my Kenyan colleagues on that. Yeah.
I appreciated the point about that it's critical when these programs start with the U.S. institution being funded to result in that transition. And you gave a nice example of a case where that happened. But I wonder at the start of a collaboration what you would recommend. I mean, how intentional can you be when you don't know what those 6 or 8 or 10 year from now, funding streams might be? So what steps do you take, say, in the first year of a collaboration to get on that path?
Yeah, that's a great question. Thank you. I think starting out with subcontracts, so at least you're providing them with a budget and giving them ownership over those funds, and ideally having the subcontract go to an institution that is going to be there for the long term, so an academic institution or a research institution, so that in addition to building your collaboration, you're also building the capacity of that institution, and they're getting those indirects. This is challenging because it might not be the most efficient way of doing your project. So I know in Kenya, we have an NGO, UW Kenya, University of Washington, Kenya is an NGO in Kenya, but we try not to use it. We try to go through the academic institutions, research institutions as much as possible. Yeah, thanks.
All right, I think we have time for one last question.
Thank you, Carey, for a wonderful talk. And thank you for walking us through a lot of the complexities when even well-intentioned, you pointed out, and can be very tricky to navigate. Can you, with all your experience, elaborate a little bit on some of the ethical challenges with autonomy, especially for a clinical learner? What things have you learned from this, and what of those have really not been resolved? Can you share a little bit?
Make sure I understand the question. So autonomy around patient autonomy?
Cultural differences in healthcare delivery, and how do you resolve them when you're there, or do you even resolve them?
Right. Yeah, so that is very challenging, as like so many of these issues are. And I think what one needs to do is to always keep your own kind of moral compass firmly in place, and respect the confidentiality and the rights of patients as you would want to, but not like go so far as to dictate how that patient is going to be managed in a specific situation. And so I think that's what the position paper is encouraging, is that all providers, when out of their own setting, defer or at least communicate, interact with those who may understand better the cultural nuances than we would. So that in going in with a very strong dose of humility, I think can go a really long way. Yeah, thanks.
I've seen several additional hands, but I think we should end and invite you all to come ask Dr. Farquhar your questions up. But one more round of applause.